Cross Symposium. It's a pleasure to be here and an honor, really, to be amongst vascular surgeons. They're very brave having a physician as chairing this, so I'll try and behave myself this afternoon. So my background is I'm professor of medicine at the University of Manchester, and I've been a visiting professor and full-time professor at the University of Miami for many years. And I've researched in the diabetic foot really for the last 45 years. With a lot of publications and a lot of experience in this area and building multidisciplinary teams. And it's a pleasure to have with us today two very distinguished vascular surgeons from the United States, although sitting immediately to my left is Dr. Anahita Dua, who's actually Scottish originally, so that's a pleasure to have someone from north of the border here with us today. And she's associate professor at Harvard, and she's published a lot of papers on peripheral vascular disease, peripheral arterial disease, related to diabetes in many cases. And we also have Dr. David Dexter, who's a clinical professor at the East Virginia Medical School in Norfolk, Virginia, and he leads a large surgical group there with a major interest in vascular disease, and I think especially venous disease. So with that panel here today, we're going to be discussing diabetic foot problems, which are immense. There are more than 6 million diabetic foot ulcers a year, as just published in a review as myself and David Armstrong in JAMA just a few months ago. And of diabetic foot ulcers, half of these will become infected, and half of those that are infected will be admitted to hospital, and then another half of 20% of those who are infected as well may end up with some form of amputation. So it's a very serious condition. And it does affect especially minority groups, ethnic minorities, and also the poorer population. For example, in the United States, amputations are 4 times more common in black origin individuals, 1.5 times more common in Hispanics, and also more common in Native Americans. And this is true across the world. Indeed, I've just come from Miami today, and if you look at the map of distribution of racial ethnic minorities and also poverty, you can superimpose this with the higher levels of amputation. So we have much to talk about today. And now I want really to talk about the need for the multidisciplinary team and multimodality. So I'm going to start firstly by asking Dr. Dua, really, what is the need for multidisciplinary teams in this area?
I think the major issue with diabetic foot wounds, for example, is that you see externally on the patient the wound, and you're drawn to that wound on the foot, and you think that you can fix that particular thing and get the patient over the finish line. The issue is really what lies beneath. It would be like being in the jungle and noticing that all of us were getting poisoned and trying to just filter the water, when in actuality, the actual poison is being placed up top in the stream, and that's what you need to go after. So in terms of wounds, there are 3 reasons why wounds don't heal: bad blood supply, pressure, and infection. Right? And if you're just focused on one piece of this, you're never going to be able to heal the wound. So without a multidisciplinary team, it is literally impossible to not only get the patient over the finish line with healing that wound, but keeping it healed so that 5, 10 years down the line, they don't get another one and ultimately get amputated. Now, because of the advances in medicine, there are so many areas where expertise is necessary, and there's literature to be learned. And we just cannot expect the doctor of today, the vascular surgeon of today, to know everything there is to know about offloading, everything there is to know about infection, everything there is to know about how to manage your blood sugar, all the new medications that are coming out. And so a multidisciplinary team is the ticket, because I can come in and fix that blood flow. You can come in and absolutely optimize the blood sugar control. Somebody else comes in for offloading, and in this way we get a perfect optimization of the patient care so that they actually get to save their leg and their life.
Well, thank you very much. It's delighted to hear that we agree on this. And, you know, I have many visitors to my multidisciplinary team, and they really are surprised that physicians, podiatrists, orthopedic surgeons, physical medicine, diabetes nurses, we all get on well. You know, who's the leader? It's a bit like communism. We're all equal. Some are more equal than others, but we won't discuss that any further. So now on to Dr. Dexter. If you could perhaps tell us about the need for multimodality care, especially in the complex, hard-to-heal ulcer.
Absolutely. I mean, Dr. Dua had it exactly right that all of us have our own unique specialty in how we see the world. And you even introduced us as vascular surgeons very differently, that her research and clinical interest is PAD and mine may be venous, but at the end of the day, we both identify the same concept around the most severe disease, which is wounds. Every wound is very unique, and the therapy that those wounds required are equally unique. That's where multiple personalities, multiple specialties is really important to sort of focus on that. But from a therapeutic standpoint, identifying infection, identifying who needs antibiotics, who needs a debridement, that's imperative in the first stage of wound healing. Identifying that a wound is ischemic, optimizing their arterial blood supply to ensure they have enough arterial supply to heal that wound. Identifying venous drainage out of that wound, optimizing venous drainage, whether by compression therapy, whether by some surgical therapy, an outflow obstruction, something to ensure we've done that. None of those can be done in the vacuum. So multiple modalities concurrently on these wounds. That's what makes them so intensive, to bring them back to the office on a regular basis and have multiple people who specialize in wounds continue to see them and then offer whatever modality therapy focuses on their particular problem.
Well, thank you very much. In recent years, and I chair the ADA, co-chair, we put out compendiums, the American Diabetes Association, every other year. The most recent one's been on the need for evidence-based diabetes foot care. And there are a number of newer therapies that are around today that actually have evidence-based medicine, which is new. When I first started 45 years ago, it was just anecdotal. So we are moving into a new era, which is good. And we also have some really good systematic reviews as well. So, for example, there are guidelines by the American Diabetes Association and the International Working Group on the Diabetic Foot. But I really want to ask you really to tell us about the need for evidence-based medicine, perhaps Dr. Dua first, in diabetic foot care and providing what could be expensive therapies for difficult to heal ulcers.
Certainly. So evidence-based medicine is fundamentally important to anything in the medical world because, as you pointed out, especially in the States, you know, we have issues with insurance, for example, that have to cover these therapies. And so ensuring that you're really doing the right thing for patients and not just wasting money is important. We all know that the mass amount of money that is spent on patients with wounds actually doesn't come from the therapy itself, but it comes from the multiple readmissions to the hospital, and it comes from the fact that they need home wound nursing and that the wounds last on them for so very long. That's really the ticket. So what we're trying to do with all of these wound therapies are heal that wound so that it's no longer in the patient's life, so they're not showing up to the ER and they're not needing multiple nurses to come and fix them over years and years. And of course, they can go back into the workforce. The problem is, to your point, we have not had excellent data in the wound care space. What we have had, to your point again, is anecdotal medicine and a lot of expensive therapies. I'll give you, for an example, there was a big craze for a while about amniotic tissue and amniotic tissue supplements, and they absolutely have a place, but good, solid, randomized control data, not really there. Now, really the only thing that has had decent evidence has been VAC therapy. Funny enough, you said, yeah, we can't do this in a vacuum, but we can do it with a VAC. Some of these therapies, you know, to really get these patients over the finish line. But then it becomes a question of, well, tell me cost. If you tell me that you're going to do X to this wound and it's going to heal the wound in 2 months, but if I just put a VAC on it and it's going to heal it maybe in 2.5 months, am I really going to drop $50,000 for that extra half month? And I'm not. And so making sure that we have solid data that not only shows that this actually helps the wound, active healing, get over the finish line, but has a cost benefit is fundamental to advancing wound care, and that can only be done with randomized control data.
Absolutely, we agree entirely. There we are, physicians and surgeons agreeing. We have to find something to disagree on, but anyway.
So I'm actually going to transition that statement into talking about agreement. So absolutely right that we need level 1 data, need high-grade data to figure out whether something does or doesn't work. But potentially more importantly is how do we then take that data and apply it to a concept of a foot ulcer? Because again, these patients are all inherently very, very different. So trying to come up with societal guidelines, criteria by which we apply the basics, I think we've done. But as you just said, some of these complex strategies, whether it's complex non-autologous tissue, whether it's topical oxygen therapy, whether it's compression therapy, whether it's negative pressure therapy, having a concept of when we apply the most expensive thing is really, really important. So just 2 years ago, there was a Delphi recommendation set made on wound care, on diabetic foot ulcers or on complex foot ulcers. And the idea of Adelphi criteria is agreement. So anything below a threshold is thrown out. So fortunately, a panel of wound care specialists, vascular surgeons, medical docs who specialize in diabetic control came up with an agreement. Do the best we can do with the basics first. Infection control, local wound care, revascularization. Once those things have been met, then talking about the addition of topical oxygen therapy, talking about the addition of pressure to the wound, is then accepted by many, many, many people that met a 70% threshold.
Thank you very much. Very important statements you're making there. So turning now to advice from societies, speaking now for diabetes as a diabetologist, the American Diabetes Association every January puts out their standards of care. And this year, 2024, those that have level A evidence include topical oxygen therapy, topical wound oxygen therapy, also negative pressure wound therapy, particularly in post-operative cases, some biologics, and the leukocyte fibrin platelet patch, the 3C patch, which isn't used very often because it needs bedside centrifugation of the patient's blood. So just tell me, in terms of your experience, perhaps you first, Dr. Dexter, on the use of topical wound oxygen therapy and how it helps those perhaps who don't have good insurance, for example, in the United States.
Yeah, so one of the things that makes my practice unique is I work for an integrated delivery network.
Right.
So while we have 13 hospitals and a medical group of thousands of doctors and nurse practitioners, we're actually, I would say owned, but we are in partnership and owned by an insurance company. And we provide insurance to the majority of patients in the state of Virginia. And that means we have to provide coverage for the underinsured, the underemployed. We own the Medicaid plans and the alternate Medicare plans as well. Our delivery network extends throughout the entire state. So while I'm in a population center of a couple million patients, we have to equally provide care for patients that live in the mountains of Western Virginia. And I think that what you just asked speaks to how we need to provide care. Bringing a patient from my city to a local wound care center weekly is very easy. Insurance is covered somewhat, and it becomes easy. But taking a patient who lives 50, 100, 150 miles away from a hospital, away from a clinic, and being able to provide them with the same level of care becomes a huge challenge. So topical oxygen therapy, TWO2, allows me to provide therapy to somebody at home. And now with the advent of virtual visits and looking at somebody on a screen and looking at a wound can show me improvements on patients that I no longer have to travel several hundred miles.
So speaking now, that's an excellent point you make. I mean, its ability to be used at home by the patient and having telemedicine to follow progress.
Absolutely.
Look, taking from Boston, which is a different setting, to West Virginia, my geography in America tells me. Tell me about the use at Harvard and perhaps how your use of topical oxygen has increased over recent years.
So it's interesting, even though they are different centers, the problem still prevails because, interestingly, this particular patient population is one that is seen and is increasing, as we know, because of diabetes across the United States, certainly across the world. And they are in our cities, a stone's throw away from Mass General where I work, and they are in our rural communities in Massachusetts. I actually grew up in Wisconsin, again, a number of patients that have this issue. And so this concept of being able to have the patient in the home get their therapy is really the crux of delivery and access to care, which we talk about so much. You mentioned disparities when we spoke in the beginning.
Right.
One of the major problems is that they don't have equal access to care. And we just go immediately in kind of in the simplistic way of saying, oh, well, it's insurance. It's not insurance. It's this idea of how can I take off from my job today and go and sit in a hyperbaric oxygen chamber for 45 minutes 3 times. It can't be done. And on top of that, they might have dialysis. They're already doing, 3 hours, 3 times a week. So the idea now of, you mentioned the oxygen therapy, coming into the patient's house, setting it up. They're going to be watching, 90 minutes of a show. It's 90 minutes for 5 times a week. If they want, they can do as much or as little. And not only do they get the oxygen therapy, but we always forget to mention that they get compression therapy as well. And it's non-contact compression, which a lot of these patients hate. So the mixed venous arterial wounds that we're seeing, they can get treatment for both of these things in an appropriate way. And it takes away some of that access to care issue. Now you add the virtual visits and the idea of now there's technology out there where actually the patient can scan their own wound. And there's data, to your point earlier again about data, where we've shown that family members can do it. They can actually get a good scan, and we really get to see, is this wound progressing or not? So not so much in the UK, but certainly for us, insurance companies want that as a touch point every week to be able to insure the patient. Now we're able to do all that from the home and more with the compressive therapy. So I think we're really hitting like kind of a revolution in the way that we manage wounds, and at the perfect time since it's exploding across the country.
Absolutely. Well, you've talked about the very high pressure of oxygen that's achieved, 90 minutes a day. You've talked about the intermittent compression, which may help with edema, of course. Do you think humidification, which it can provide as well, is helpful in your experience?
Oh, absolutely. A desiccated wound will never heal.
Right.
In some cases, a desiccated wound may form an eschar to then protect the humidity underlying the eschar. But I think triple therapy, and we've made mention of the first two, which is oxygenation at higher concentration, localized pressure, and humidification. I think you're right. Understating humidification is probably a mistake.
Yeah. And your usage, is it primarily as outpatient or ambulatory care? Or do you start within hospital and move patients out earlier, thereby saving money as well?
So for my practice, we start things in the hospital when we think there's a barrier to entry, when we think a patient's not going to be able to understand how to do something. In this case, it is such an easy transition that we initiate this always as an outpatient.
Okay.
So it shows up, and the nurses can show up and help educate a patient on site, and away it goes. And from a compliance standpoint, because we do utilize a lot of contact compression with Una's boots, a lot of lymphatic compression with lymphatic pumps, the compliance rate with this has been spectacularly high. Now, some of that may be the request, that we say, I want to see a picture. We stay very engaged in our ulcerations that we think are ischemic, and the patients seem to partner with us quite nicely on that from a compliance standpoint.
Okay, well, we've talked about a lot this afternoon, and I hope that the audience has enjoyed this. We've talked about this very new therapy, its ability to be used at home, its 3 points, the topical oxygen itself, humidification and the intermittent compression, which helps with edema, and most importantly, that it has an evidence base and it has strong recommendation from the American Diabetes Association, and also a recommendation from the International Working Group on the Diabetic Foot. So I think this is going to be increasingly used with very good feedback from patients, and our limited experience in the UK is that patients like it, they can manage it at home, and it saves those trips to hospital. One final question. You mentioned dialysis. Now, we published years ago from Manchester the outlook for those on dialysis due to end-stage renal disease as a consequence of diabetes who had a foot ulcer or even amputation. It's horrific. The mortality is worse than most major forms of cancer. Now, increasingly, there's nothing that is licensed for use in patients on dialysis because they're all excluded from trials.
Right.
So I just wondered, your experience, have you used this, I'll ask both of you, in patients on dialysis, and perhaps the days you're on dialysis is a good time, you've got a captive audience to actually do this during the dialysis period at the location wherever the dialysis is being performed, presuming they're on hemodialysis.
Oh, 100%. I mean, that's actually one of the, I think, even in the States now, the FDA has moved away from, I want to know patency of the stent, I want to know reintervention rate, to, was the leg on the patient's body a year from now?
Yeah.
All things considered. And that's actually clinically what we've always been taught to do, right? To think about it that way. And so, to talk about a patient like on dialysis, for example, and this idea of like being excluded from trials. I mean, we've seen it with women, we've seen it with certain populations, we've certainly seen it with people on dialysis, because people originally needed to make studies that fit a particular mold for one variable. But now with this shift in not only the clinical way of approaching things, but even the FDA in approaching things, we are now seeing real world, finally, generalizable data. And so, I just presented a Clarity study, which is basically an observational study that looked across the states in 2024 at what does our CLTI patient population look like. And in that study, enrollment, 25% of patients had end-stage renal disease.
Right.
And we know not only are these patients still around and increasing, unfortunately, in number because of diabetes, but they're also living longer because we have better technology and treatment. So now we can't just say, oh, a person with diabetes is going to pass away in 2 years, let them just have the wound. That's not okay. We need to allow them to enjoy those years and make sure that wound heals. And a therapy like this that is shown, because they included diabetics, to have a benefit should be the way to go. And I love your idea about having oxygen therapy available in a dialysis suite, and everyone just gets this on their feet while they're sitting around. That's genius.
Captive port.
audience.
captive population there.
Right.
And have you used it in patients on dialysis, actually on hemodialysis,
I
either
have.
during it or at home in the days in between?
I have. I think the comment on dialysis populations and survival is really important. So the data that we used to quote, where a 50% 1 to 2 year mortality, seems to not be true anymore.
Right.
And I don't know that I can explain why, whether it's better heart disease, diabetic disease, end-stage renal disease management, but a combination of increased medical therapies shows that these patients do outlive the survival curve that we saw in our medical education 10, 20, 30 years ago. So I think not offering therapy to somebody based on old data is a problem.
Right.
On the alternate side of that, even if somebody's within the last 1 to 2 years of their life, the quality of their life is significantly more important, perhaps, than the quantity of that life. So removing a leg because of a stagnant ulcer that gets infected is a giant cause of mortality. So anything that we can do with multimodality therapy to improve a leg ulcer, even in the last 1 to 2 years of life, can keep somebody ambulatory, keep somebody at home, keep somebody with their family, rather than hospitalized. Once a leg is removed, the rehospitalization data, the number of hospital days per year data goes up exponentially. And that is, as you just said, the FDA has changed their view on just keeping the leg attached. I think we've done that too.
Right, exactly.
That's very good. I mean, one thing we didn't actually talk about was the durability of healing. And of course, the one good thing about, or many good things about the RCT, published in Diabetes Care a few years ago with TWO2, which had such positive outcome, is that the durability of healing, they remained healed. Some people say it's easy to heal a diabetic foot ulcer, but it breaks down within 6 months. The healing rate was maintained. Many more patients, a huge number of patients who had been on the topical oxygen rather than the control, at a year even. Have you found this in clinical practice?
I found it in clinical practice. I think trying to understand it is important, whether it's the increase in collagen deposition in a wound that sees topical oxygen therapy, or whether it's the neovascularization that happens at the skin and cutaneous level from topical therapy. I'd love to be able to give you a reason as to why, but we've seen it in the arterial space and the venous space that you're right. The goal is not just to heal a wound. It's to heal a wound and to keep it from coming back. And the data, at least the early data, suggests that's very true.
And the other thing, of course, you can use topical wound oxygen with most other treatments apart from back. That would be difficult. So you can use it with most dressings and many other things, even an UMA boot. So do you use it with most other things?
I do, yeah, especially for the venous patients, actually.
Right, okay.
As I mentioned, there is compression, and then you can, if the patient will tolerate your regular Una boot, and then you put that on top. And there is a lot of data that's out there even in animal studies about oxygen and collagen. The collagen that's put down is stronger, and so it does. Again, we don't know exactly in this particular case what's specifically going on because no one's done samples of that tissue. But it probably is that the collagen that's being replaced. We were always taught that you have a wound, the wound heals. It always heals at 80% the tensile strength that what it had originally. But ideally, if it keeps breaking down again and then in these chronic wounds, if you can get at least some of that tensile strength to stay plateaued, you are potentially going to be able to keep the wound healed for longer. So it does make a lot of sense scientifically why oxygen therapy would work. And I think, honestly speaking, the reason that we haven't used it as aggressively as we should have is just because it's difficult to do. Hyperbaric oxygen is hard to do because patients have to get it prescribed, they have to go to a location, there's risks involved, and this takes away all of that.
Right. Okay, well, we've really covered a lot this afternoon. We've covered these new therapies. There are many we've talked about, especially the ADA and the International Working Group guidelines, but obviously we've focused on topical wound oxygen therapy, its benefits, the outstanding results from multiple trials and multiple systematic reviews, which really show that this is an up-and-coming new therapy which is widely used across the world now with great advantage to patients at home, in hospital, and also with the ease of application and how our patients really enjoy this because they can see the effects of this during telemedicine when they're taking their own pictures of the wounds or even videos of the wounds before and after. So this is a very exciting new therapy with really no side effects, which is outstanding. And there are not only RCT, the FDA now likes also real-world data, as Dr. Dua pointed out. And there are real-world data as well to support it. So I'd like to end by thanking so much our two panelists. We had a lively and positive discussion. I hope you agree, and I hope this is of use to your practice wherever you may be. Thank you very much.
Thank you.